Good afternoon. My name is Dr. Ted Waters. I am the Director of High Risk Obstetric Services here at Oishei Children's Hospital and also for the Collegial Health System and for the University of Buffalo. Today I'm going to be talking about hypertension in pregnancy, and this is updated guidance for chronic hypertension and for pregnancy-associated hypertension. The aims of this are to review the findings from the recent what's referred to as the CHAP trial, the chronic hypertension and pregnancy trial, and differentiate the treatment of chronic hypertension in pregnancy from patients with a hypertensive disorder of pregnancy. The CHAP trial was published just over a year ago in the New England Journal of Medicine. This was a study of 2,400 participants with hypertension diagnosed before 23 weeks, and I'll be coming back to that again a few times during the talk. And they were randomized into two groups, those given medication with labetalol or extended release nifedipine to a target of less than 140/90, or control patients who were not given therapy unless their blood pressure exceeded 160 systolic or 105 diastolic. There were two sets of outcomes that were looked at. The primary was a composite of the development of preeclampsia with severe features, medically indicated delivery before 35 weeks, pregnancy abruption or fetal death, and the secondary outcomes were a composite of newborn complications, maternal complications, preeclampsia, and preterm birth. Just as a reminder, labetalol and nifedipine are two of the most common medications given for blood pressure control for chronic hypertension in pregnancy, and the doses that are commonly used are listed here. Methyldopa is also an option, but it's not used in the trial, and it's not commonly used anymore in obstetrics. This table summarizes the primary findings of the study, which were different between the groups. The primary outcome was lower in the patients that were given medications for control of their blood pressure. There was no difference in the finding of babies with growth restriction. And interestingly, the outcome of perinatal death, which is either a stillbirth or a newborn death, was higher than expected at 3.5% and 4.3% in both groups. The key findings of this trial were in pregnant patients with chronic hypertension less than 23 weeks, a strategy of targeting blood pressures to less than 140/90 was associated with improved pregnancy outcomes. There was no identified increased risk of growth restriction or stillbirth in the treatment arm. However, the study did not establish an ideal goal for blood pressure, but rather a threshold for treatment. The observed risk of stillbirth and neonatal death was higher than expected in both groups. The findings only apply to the pregnant patient with chronic hypertension less than 23 weeks. And in their statement about the trial from the American College of Obstetrics and Gynecology, they reminded that acute, severe, or persistent elevations in blood pressures in the second half of pregnancy, meaning beyond 23 weeks, warrants further evaluation and a period of observation because of concerns for superimposed preeclampsia on top of chronic hypertension. Further, the CHAPS study protocol required exclusion of preeclampsia by clinical diagnosis workup before any escalation of medication that was used beyond 20 weeks. Chronic hypertension in pregnancy versus pregnancy-associated hypertension. And I just want to remind everybody about the differences between these because I think it is important for some of the later slides. So pregnancy-associated hypertension, which is generally referred to as gestational hypertension or preeclampsia, is a systolic blood pressure of 140 or more, or a diastolic blood pressure of 90 or more, on two occasions, at least 4 hours apart, after 20 weeks of pregnancy in a patient with previously normal blood pressures. Chronic hypertension is hypertension that either pre-exists the pregnancy, hypertension which is identified prior to 20 weeks, or hypertension that is first diagnosed in pregnancy but does not resolve postpartum. A more difficult area to clarify is chronic hypertension that then develops preeclampsia. And unfortunately, this is a complication that can affect up to 50% of patients with chronic hypertension who will go on to develop superimposed preeclampsia. Superimposed preeclampsia on chronic hypertension is very difficult to define, and it's often a diagnosis of exclusion. There are no predictive tools or tests. And in general, the guidance given again by ACOG is that this is defined as a sudden increase in baseline hypertension or a sudden increase in proteinuria that should prompt immediate assessment and consideration for a consult with a subspecialist, such as with maternal fetal medicine, to clarify the situation and if the patient has superimposed preeclampsia. So going back to the CHAPS trial versus hypertension disorder of pregnancy, the CHAPS trial was aimed at clear chronic hypertension before 23 weeks and required exclusion of preeclampsia after 20 weeks. The CHAPS trial was not aimed at patients with gestational hypertension, preeclampsia, or those with superimposed preeclampsia. Treatment of preeclampsia blood pressures is only indicated for control of severe persistent hypertension, a systolic of 160 or a diastolic of 110, some centers use 105, during inpatient expectant management at an appropriate center. Isolated mild blood pressures of gestational hypertension or preeclampsia should not be treated. Do not apply the CHAPS trial approach to this situation, and I have this in red because this, I think, is a very important take-home point. The management of pregnancy-associated hypertension is as follows. For patients with gestational hypertension or preeclampsia without severe features, this warrants close surveillance for the development of severe preeclampsia or worsening maternal or fetal status. This is done generally with weekly office visits and blood pressure checks, and labs including a CBC and a CMP. Fetal growth should be assessed every 2 to 4 weeks, and fetal surveillance is also recommended with biophysical profiles or non-stress tests. Delivery at 37 weeks is often recommended or sooner if other complications develop. If a patient develops severe preeclampsia, including if superimposed upon chronic hypertension, this often requires admission and delivery if the patient is after 34 weeks. I do want to highlight that within this, starting antihypertensives for the management of this diagnosis is not recommended. For patients with preeclampsia with severe features, including those superimposed upon chronic hypertension, this often requires admission, assessment of the fetal status, again with non-stress tests, assessment of fluid and growth, control of severe blood pressures, and those would be blood pressures greater than 160 systolic or greater than 110 diastolic. As before, some centers use 105. Labs including a CMP, a CBC, and assessment of urinary protein. Steroids for fetal benefit if they are less than 34 weeks. Delivery if after 34 weeks, and magnesium for seizure prophylaxis. Transfer to a higher level of care is often appropriate if the situation allows. So the key takeaways from this are superimposed preeclampsia happens often, but is difficult to define and warrants a high degree of vigilance for patients with chronic hypertension. After 24 weeks, but certainly after 28 weeks, do not assume worsening blood pressures or chronic hypertension and may in fact be superimposed preeclampsia, and this potentially can be severe preeclampsia. The initiation or escalation of medications after 24 to 28 weeks for worsening blood pressures is a potential concern masking severe preeclampsia and should only be done in concert with a maternal fetal medicine provider. So these are the references that were used for the talk today. These include the 2 references from the American College of Obstetricians and Gynecologists related to chronic hypertension and preeclampsia, as well as the New England Journal trial regarding the CHAPS study. Thank you so much, and please join us again for our next talk soon.